to today's Health Equity Action Time, or HEAT 2023 series with a focus on mental health. And this is a continuation of a discussion we began last month during Mental Health Awareness Month regarding the system of mental health care for children and youth. So if we can go ahead and pull up our slides.
Yeah. Well, I'm pulling up slowly intentionally because I know people are rolling in.
Yes, absolutely.
Great to see everyone on a Friday. Let's see here. Okay, hold on.
Yeah.
Hold on, sorry.
Grace.
And yeah, you can see the slide, right?
Yes, so we can see these.
Awesome.
Thanks, Anda. It's
Yep.
great. And it's great to see everyone here today. As it said, welcome to today's Health Equity Action Time session. And before we actually get started, we want to start with this land acknowledgement. We would like to acknowledge the Ramaytush Ohlone people, who are the traditional custodians of this land. We pay our respects to the Ramaytush Ohlone elders, past, present, and future, who call this place, the land that UCSF sits upon, their home. We are proud to continue their tradition of coming together and growing as a community. We thank the Ramaytush Ohlone community for their stewardship and support, and we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. We also want to acknowledge the commitment and expertise of our planning committee members who are listed here on the slide. Thank you so much, everyone, for your hard work in helping to pull this HEAT series together.
Okay. So just as a quick reminder, and I wonder if I'm just thinking that people might be having trouble from the registration, but just double check one thing. Okay, just very quickly, I'm going to give a brief overview of where we've been on this journey with HEAT. So just very quickly, we're building off of what we did together in 2022, the HEAT series, with the overall goals for this year, really taking the feedback that we heard from people to have regular ways to get together to learn and share about how we may improve our care of the patients we're seeing with mental health and behavioral health needs. And so we developed this series for this year in the 2023 series as more frequent touch points, monthly 1 hour space for people to share and discuss opportunities and barriers. And so if anyone wants to look at the overall event of HEAT, you can look at put your camera on that barcode or the QRS code, sorry, and pop that up. And also we'll put the link in the chat. So our goals are to really highlight our progress and ongoing barriers and opportunities we have to implementing critical steps and priorities, and also take steps to take advantage of opportunities and remove some of those barriers. And this particular webinar objectives here, for this particular webinar, our objectives are: one, to ground our discussion in a case, to highlight different system resources and limitations for a patient with mental health needs in San Francisco, and describe elements of effective coordination of care between primary care and schools, school-based mental health, and utilizing the child adolescent psychiatry portal in supporting a child or adolescent with mental health needs. And lastly, identify some of the ongoing system barriers to providing care for children with mental health needs and adolescents with mental health needs. And just like a heads up that we will have little breakout discussions, because again, that's part of the feedback we received. So totally fine if you're on your phone and running around, as like many of us are, but we'd love to still have you in those small group discussions. So today I'm going to quickly review the case that we grounded these two webinars in, and then the system touch points that we're going to highlight today, as I mentioned, are the school coordination piece and the child adolescent psychiatry portal as a tremendous resource for us. And then, as I mentioned, we'll have some time for reflection and small group discussion. So, I just, as a reminder, the whole HEAT series really evolved out of brainstorming from many of us on our planning team and others around what we needed to improve the care that we were providing for children and adolescents in the Bay Area that have to improve their well-being and mental health outcomes. And so the concrete next steps we identified from that series, and you can, again, put your camera on that QR code to pull up our 2022 HEAT series. It has the links to the slides and to our recordings. We're to really build capacity through training and workforce development and improve partnerships with communities, including our important partnerships with schools, and then increase our direct clinical services and provide infrastructure for cross-sector and cross-silo collaboration, such as the HEAT series is doing, and scale and sustain integrated behavioral health services. So from the first session that we had in May, I just wanted to highlight that we were focused on 4 system touch points, and we covered 2. One is the integrated behavioral health resources we had in our pediatric clinics. And then the important partnership we have in providing care with managed care plans and the care management services they have in supporting our patients who have behavioral and mental health needs. We also identified resources and limitations and facilitators and barriers that we discussed in our breakouts, and a summary of those discussions you can find in the link that we'll put in the chat. And you can again see the recording from the last HEAT series of this year in that QR code. All right, so very quickly, that for those who weren't able to attend the last one, the case that we are basing this in is a patient that I actually saw in clinic, and the patient agreed to share his case, and of course I've changed the name and the initials and everything. Have made everything non-identifiable. But so this patient's 13 and had numerous visits in the past year, but very inconsistent primary care. And he was very, very quiet when I saw him, like very retracted into himself with very minimal communication. And his voice was really low, almost like he was trying to swallow his words back in. He came with his mom and stepdad, who seemed really engaged and eager for help. And they identified some priorities, including some leg cramps. He was missing a lot of school. He stated he also had some daytime sleepiness, poor attention, and may have had a history of a diagnosis of attention deficit hyperactivity disorder, and wanted help with an individualized education plan, or IEP. He had a very high BMI and reported some daily sugar sweetened beverage intake. And then had a PHQ, or his depression screener, of a score of 14 without any suicidal ideation at that time. And he was getting some counseling at school, and was also describing having trouble with sleep onset. And just a little background, he's in middle school. He described himself as feeling very lonely. When I asked about a strength he had, he thought for a while and said, well, he's nice, but really was having trouble identifying anything he was good at. And in history, in the notes, I could see he had moved here from another county, had a history of interpersonal violence that he had experienced, and some verbal abuse at the age of 5, for which he had received some therapy, and currently lives with his mom and stepfather, whose preferred language is Spanish. And as I mentioned, they were both here visit. So I had shared in the first webinar, I'm not going to go into too much detail. Of course, there's a lot of different things floating in my mind around differential diagnosis, and like this is the first time I'm meeting him. So it was a little bit overwhelming as a provider, and I was trying not to like get too panicked and like thinking, how am I gonna, what resources can I give to him in this initial visit, and what can I get started in a realistic way for him. And so we did touch base with the integrated behavioral health that we have in the clinic, and also with how the incredible resource of partnering with the health plans, care management services. Okay. Oh, and the family has there's no family history of depression. As a follow-up, he had multiple visits to urgent care and primary care over the next 2 months for abdominal pain and nausea. He was being bullied at school. He described headaches in urgent care and had some suicidal ideation. And there were multiple messages from urgent care to me as the primary care provider concerned about his mental health. I'd also learned that school counseling was ending with the school year. And so I had referred him to the behavioral health team in our clinic, and he had started services, some services with them. And as I mentioned, he received some case management from the health plan, which is super helpful. And then mom and the patient expressed interest in treatment with medication. So again, these are the touch points: clinic, the health plan, the school services, and child adolescent psychiatry portal, particularly around medication management in this case, although they offer, you'll hear later, a lot of other services. Okay. So I'm going to turn it over soon to our guest speakers here. I'm really grateful to have, but I'll just mention, so I was thinking, okay, the school coordination piece is around, I had given the family the Vanderbilt screening for ADHD to give to the teacher. They're both paper forms. There's no way I could send them by electronic. So I'm giving the family papers, which I would lose with my own kids. So I was, nervous about that. I think I wrote my email on there for contact information. And I was also referring, I engaged our behavioral health team to help refer for psychoeducation evaluation to the school. And I was really, really fortunate. I was so grateful that the school nurse at his school, and I'm going to quick shout out to Lori Bruckner, the school nurse, who's like so great in communicating with me, reached out to me by email. I sent her my cell phone. And so she also left me a voicemail, and we finally connected by cell phone and a conversation. But in the email, she said, I'm the school nurse at this middle school. I see TM frequently. His mom and I also speak often. Attached are the release of information, ROI forms from both San Francisco General and Unified School District. So that's one area we know in the systems can be really challenging, is these bidirectional release of information forms that have to get passed, usually in paper format, which is also challenging, through the family, which is, hard for them to bring back and forth to the different systems. But she continued to say, as an FYI, the school psychologist received the written request for psychoeducation testing, which is awesome. And when are some good times for us to speak? Very concerned about TM and would like to work as a team with you to help. So that was just fantastic, and doesn't always happen, unfortunately, in spite of like everyone's good intentions, and just, it seems like it should be easier. And honestly, in our clinic, I think we have a Google spreadsheet with all the schools and contacts information so that we can email school personnel. But that doesn't always happen, and it has to get updated in a somewhat archaic way, I guess, by having this electronic Google spreadsheet, which I'm so grateful we have. But it requires in real time, like you're in clinic, you want to reach the school. By the time I usually get the spreadsheet up and I'm emailing or trying to call, it's like past usual school hours. So voicemails left, and it's not ideal. So just pointing that out from a realistic standpoint on the ground as a provider. So I'm going to turn it over now because I really want to highlight what are the resources on a very high level, and in a future webinar we could go more deeply into the school district's resources. But I'm very grateful to have Corey Peck, Supervisor of Student and Family Services at San Francisco Unified School District, and Francisco Alvarado, who is the Behavioral Services Manager for Oakland Unified School District, here today to share with us just again like a big overview of different resources we should know about as providers. I'll turn it over to you, Corey and Francisco.
Thanks, Anda. Hi, my name is Corey Pock, and I work for San Francisco Unified School District. And I know the nurse that you're talking about, and I'm going to pass it over to Francisco for his introduction, and maybe we can have a conversation.
Hi, everybody. Francisco Alvarado here with Oakland Unified School District. But yeah, I don't know. That'll be it. Yeah.
Sure. Yeah, we just met 10 minutes ago, so this is going to be super dynamic. So I really appreciate when a provider reaches out, and we do update that spreadsheet annually. But you can also, for any SFUSD student, you can email sflink@sfusd.edu for any connection. If you're unsure, if you're pressed for time, I urge you to use this student, family, parent link line. And we opened this during the pandemic when we were trying to reach students and families where they're at in their homes. So just to give a brief overview, there should be a social worker or nurse at every school, and at our high schools, a health worker. And some of our middle schools, we're expanding our middle school wellness programs similar to our high school wellness programs. But as you know, there's staffing shortages everywhere. So we have many open school nurse positions. If you know any school nurses or any nurses that want to become a school nurse, and social worker positions as well. So just putting a pitch out there. So this is a great example of coordination. We do need to release some information. We follow FERPA, the Education Rights Privacy Act. And also our providers follow their ethics and legal codes of their professions. I'm a clinical school social worker and a school counselor by training. So we really promote interdisciplinary collaboration. And so earlier, I'm glad that you mentioned the request for psychoeducation assessment. I'm really going to promote that. A request for assessment really speaks to, and there's a number of people on this call I see that can speak to this issue too, just as a starting point. It's a starting point to open the conversation about what are the root causes, what are the needs going on for the student and family right now, and how can we work together to serve that. And we've all been through the past few years of the pandemic, and universally and in a community, we've experienced a lot of challenges and barriers. So we're in the business of removing those barriers so that people can access services, especially now with all of our mental health crises and all of our social, housing, et cetera. It's not an individual level situation at times to address. It takes a team, it takes a community and schools. So I would encourage you for San Francisco students to reach out to the schools, to the nurses and the social workers and the health workers at that site, and even the principal for elementary schools. Many times they're the ones who are in deep contact. But we center is the relationships and the partnerships with students and families and over time. So we know that time is the most important part about relationship building, trust, and engagement. And we want to work together to have every student have a medical home so we can coordinate services. So that starts with everything from making sure they have the immunizations to enter school and stay in school and promoting their attendance. And so oftentimes we are learning about students' health needs, learning about their parents' health needs, which is a barrier to the students' attendance. So holistically, if we can support the whole family in functioning and accessing the services they can and that they have a right to access through their health plans, through their schools, et cetera, for their siblings. So a lot of times people have multiple siblings in their family or cousins that can also benefit from these kinds of services. So I'm really pleased to hear about the engagement of a kind of more shyer student, because those students can fall under the cracks, and really digging deeper to find out. Even parents themselves don't know about the bullying that's going on at schools at times. And so any opportunity you can find out to do that deeper assessment. And then what follows is the services, what actual services that we can provide, which can fall under an IEP, but also can fall under a 504 plan. So people might have heard of IDEA, but we really want to focus on providing students with the least restrictive environment, which is the more social and academic opportunities and access to instruction and the general education. All students are general education students. And so if we find out what their needs are, and we can accommodate those needs and provide customized, individualized learning, that's really the best case scenario. So whether it be a student with a health condition, student with a temporary health condition, a family struggling through some housing instability or other immigration issues, or having to deal with family transitions in their family structure, like there's a lot of things that we can support as a community, and it doesn't always have to be at an individual level. With that, I'm going to focus. I'm going to transfer my mic to Francisco.
Well, I mean, I don't want to repeat everything you just said, because yeah, it's, I think, similar in most school districts. I think what I will add to everything you were just mentioning is more like some of the barriers to a lot of like success stories. And for example, where I was mentioning, staff shortages, lack of social workers, therapists, etc. But so that ends up happening. You usually get like a TSA, teacher special assignment, running the mental health program in a school site, and not having the foundational knowledge of understanding I need an ROI, I need to document this, I need to follow up. And that's where you get all the students fall into the cracks. Even like right now, before this call, during our summer program, I've just got an email about a student who had needed a check-in a week ago, but they just learned, oh, we should have contacted somebody to help us manage behaviors. I started working with OUSD as a community school manager, and I recently transitioned to the behavioral health program manager. So now I'm looking more over all the schools in OUSD. So I get to go now to different schools and help them out, make sure they have a functioning behavioral health program. And with that perspective, I'm getting is that I'm usually focused on a lot of schools that have a person who does have a mental health background, adjusting to these changes and knowing how to manage, like Corey, you mentioned all those things, how to do an assessment on getting family information, the neighborhood, all of these things that come to second nature to most therapists are not happening sometimes at the school level. And we're actually trying to figure out how to, we have a retreat next week, as all was in this district side. How do we communicate this to all of the schools at the same time, level trainings? I mean, teachers and school staff have so much trainings about schools. I think that's the other part. Like, there is the school mandate, which is like attendance, grades, classroom. And so there's so much compacted into a school, and sometimes mental health service and protocols have to be snuck in there somehow. And which just creates a lot of, again, tension, because now we're adding more steps to what we're already providing at the school sites. And I see this a lot, like sometimes with clinics or hospitals want to collaborate with schools, but the biggest step is like that communication, trusting that the ROI is going to be respected. Because I get a lot of those calls, like, so I just don't trust, like, oh, I get it. Like, when we wrap around the FERPA, I mean, I'm a therapist by trade, so I fully understand HIPAA and all of that. So there is that level of trust that still, I feel like it needs to be built somehow. And with a teacher running without fully understanding HIPAA, there is a little bit hesitation from the other side, and I do see that a lot. But yeah, I just want to kind of add that, because I think you covered pretty well, Corey, on how school supposed to function, I would say, when we have all the staff members there, like, and everything. And I think, especially in the Bay Area, how people are just leaving. Also, a lot of mental health professionals leaving the area because of housing too expensive. We are coming across also, like, even if we do identify support, there isn't people enough therapists to provide the one-on-one therapy students need.
Thank you both so much for that overview. I know there's so much more that could be shared. There is a question in the chat about how students access mental health services in the school districts, especially if there isn't a school-based health center, and does a student need an IEP, an individualized education plan, to get school-based mental health services?
They do not need an IEP. I'll just go from bottom up. And we have various streams in San Francisco. I'll speak to San Francisco specifically. We have interns, we have school social workers, we have community partnerships through our Beacon programs and after school programs and other community agencies. And we have ERMS providers, education related mental health service providers, in our partnership with DPH, who's our contracted providers. So, and we have school psychologists too. So the menu varies by site and by student need, but generally the services are provided during the school day, and if they have an IEP during the extended school year and summer school, if they have a summer school program. So its focus is early intervention and brief, and sort of we really want to focus on supporting learning and family engagement, and also finding out how we can kind of broker the services in the community for the families and students, in terms of the schools being a hub. We see them every day. I mean, we missed them during the pandemic, and so we realized the touch points are very important that you mentioned, Anda. So like that whole being a hub and a spoke for all these different kinds of services, and more intense or ongoing or brief intensive services are so important. And so I just want to note that education and healthcare systems have in the past, or maybe currently, demanded that our patients, our students, fail upwards until they have a crisis or a systems failure. But we want to catch them early, and we want to kind of dig deeper, and we want to kind of wrap each other in the services, and really over time monitor how they're doing.
Just to follow up, and maybe Francisco, you can add to this. Is it a teacher then, or sometimes like a clinical reach out, or what do you think is the most common way a student's identified and set up for services in the school? And maybe I'll turn to you, Francisco.
Yeah, I mean, with OUSD, we're utilizing the COS system, the Coordination of Student Service Team model, where and OUSD has a partnership with where they develop a whole referral-based OUSD force, where any within OUSD email can make a referral for a student to get services. So usually, say a hospital A, we know the student needs services, they will end up calling the school and ask who is the COS coordinator, who is the person in charge, so they can let them know, hey, this student is going to need services, so they can write that referral. And usually within that meeting, in the COS meeting, you have the COS lead, school psychologists, nurses, after school program, all the players that can either provide from tier 1 to tier 3 level of intervention. And that's where it gets assigned. Now, just going back, the barrier with these COS meetings, sometimes they are led by non-clinicians, and they don't have the full knowledge of assessing need right away. They might understand well enough to ask if they have medical or private insurance, but it comes to a challenge where this is where I get utilized a lot. Case, these details, would these be appropriate for a one-on-one therapy? ERMS, what are we looking at? Substance prevention, things like that. So that's usually how we try to keep everything with OUSD through our COS process and our internal database of referral, which OUSD force.
I would say it's similar in San Francisco for the coordinated care teams, or they're called student assistant programs teams in other school districts as well.
And then there's one last question, but I may have you answer in the chat if that's okay, about self-referral in each unified school district. Okay, so I'm going to keep us on time here, and so I'm going to move forward. Thank you. And I really just so appreciate our unified school district partners. Thank you for joining us, and for, most importantly, for the incredible services that you all provide. I think I'm on the wrong, hold on a second. Okay. Are you all seeing the right slides here? Yeah, Patriot, can you give me a thumbs up if you see the right slides?
I'm seeing the initial clinic and school coordination.
Okay, perfect. Thank you. Okay, hold on. So, sorry, I did this the wrong. There we go. Okay. So, I feel fortunate in the sense that we've had over the years, psychiatry has partnered with us at our clinic. I'm at San Francisco General Children's Health Center, in getting us as providers as primary care providers comfortable starting and managing some basic medication treatment with antidepressants. And so I generally am comfortable, and we have this like little binder. Again, it seems kind of old school, but we have a binder and it has, you know, the like kind of an algorithm and like treatment recommendations, best practices. That's super helpful. But in this case, I'm really grateful for the Child Adolescent Psychiatry Portal, because in this case, it was a little more complicated. He seemed to have different layers with insomnia and a history of trauma, and just wanted to make sure and he's also younger than some of my patients at 13. So I wanted to make sure we were starting him on the right medication. And so I reached out to the Child Adolescent Psychiatry Portal for a consultation. And I'm going to turn it over to Petra, who's director of the CAP Child Adolescent Psychiatry Portal, to provide some of the other additional resources. So I reached out for medication, but there's so many other ways that we can and should be using CAP as a resource. So Petra, I'm going to turn it over to you. What should providers know about integrated care and multi-system collaboration opportunities with CAP?
Thanks so much. If we can go to the next slide. This is, so, and I guess before jumping in, I just really wanted to express a lot of gratitude for this series, for Anda and all of our team putting this together and thinking about ways that we can help to develop the workforce back to the initial objectives that we were talking about. A lot of primary care providers tend to feel less, may not feel as comfortable addressing behavioral health conditions for lots of reasons. And the need is so great and ever increasing, as Corey had said. And so we need to kind of get more creative in terms of how are we addressing needs. And so this diagram is just in here to think about, you know, a possible continuum of behavioral health integration. There are lots of different ways to do this, like the integrated care clinic at San Francisco General, or some of the integrated care locations that are at Children's Oakland, in the school-based health centers, and in the FQHCs. And there are lots of ways to kind of help develop capacity within the primary care workforce. So this diagram just shows kind of, you know, on the left three, you've got things that are self-guided resources, and then the middle four are building PCP capacity. And then at the far end is kind of a more, you know, face-to-face, what you would consider like a more historical type of care model, although in this case, it's a virtual visit. And so CAP offers the Project Echo series that's led by Dr. Joanne Jung, who's here on the call and part of the committee. And next, the remote telehub consultation, which is kind of the primary mode of consultation that we're using. And then also next, we have been beginning to offer e-consultations or asynchronous written consultations. Next slide, please. This is just a diagram that shows that that pediatric mental health care access programs are kind of an established model that was first rolled out statewide in Massachusetts in 2004. And then the next state was in Washington State in 2007. And since then, HRSA has really gotten behind this and has offered funding to a number of states that have gotten started and or been able to grow their statewide programs. And we were a 2021 HRSA recipient. And the key components of these programs are really the in the moment consultation that is about kind of helping to coach somebody on the resources that are available and help to kind of bring that knowledge to life. Because I think, you know, in terms of algorithms and resources and information, it's all out there, but it's really about developing the confidence and deepening knowledge and applying those skills iteratively over time so that you develop a certain skill set for managing mild to moderate behavioral health conditions in primary care that are often the first place that they present. And then to complement that, and also in order to develop trust and build relationship, the educational component is really key. And then the third component is having care coordination, having resources, having off-ramps for when things become kind of beyond the scope of what can be managed within primary care. Next slide, please. This is just a snapshot of our main consultation services. So the first step in this process is to speak with a psychiatrist. And although, so we track kind of what's the primary question and then what's the secondary question. And of the primary questions, 65% of those are stated that they're about medication. But we also ask about diagnostics and treatment planning and, you know, therapy and also language pearls, motivation. And we really try to think about things in a really holistic way, not just that we're teaching PCPs how to prescribe medications for kids, but how to think about the whole, you know, whole child, whole family system that complements ways that you're already doing that and together with other care team members. We're also, excuse me, we're also offering an expanded psychologist consultation that is for specific ages, so early childhood. Lauren is on here and she's delivering consultation for youth ages 6, 7 up to 21. And Dr. Lindsay Brewitt is here. She specializes in eating disorders and is also very well versed in a number of evidence-based practices. Then we've got consultation on things like autism that's just starting with Dr. Indy Lynn, and we'll be looking at substance use as well. And then we have care coordination for families that really need a lot of extra support and have not been able to access care for whatever reasons. Next slide. This is a snapshot of our current training offerings, and we really would like to kind of take our pediatric mental health boot camp that's a live training a little bit more on the road and expand that. We've finally been able to have some more in-person training, and we hosted this in Fresno in September of last year, and it was really a lot of fun and really successful and helped us to develop more relationships there. And then we're also planning to offer a deeper dive echo on certain topics for maybe more providers who have already gone through kind of the basic echo training and already feel pretty confident and comfortable. Next slide. This is a brief snapshot. So Lauren Hack has been leading our school-based consultation efforts. And this is a snapshot of the Project Echo series that we had delivered over this past school year, just thinking about trying to meet kids where they are, and often that is within schools. And so we want to help develop workforce capacity within school-based health centers and also within school settings. Next slide. This is a snapshot of our resources page, and we kind of build a little more deeply into what's the education and support resources, and also learned, thanks to Corey, we don't want to call this an IEP request letter, we want to call it an assessment request letter. But we have a number of different resources here on all kinds of conditions, both for families and providers. Next slide. This is a little bit broader of an overview of the different resources that we have. And we've had over 65,000 page hits and then over 15,000 unique utilizers who have been accessing these resources. Next slide. So, and this is just a little, excuse me, a brief quote. We collect both qualitative and quantitative satisfaction data. And I think this quote really stands out because it talks about helping to mitigate burnout, feeling like you're alone and doing this work that is often really hard with very little time, and perhaps with less comfort or confidence than you would like. And when we feel like we can't manage something that's in front of us, that is a contributor to burnout. So thinking about having that kind of real-time coaching and guidance can help you feel like you want to go ahead and do that follow-up visit rather than what may feel like the easier thing, which would be to send a youth to the ER.
Mhm.
Next slide.
Right.
So, yeah, and just I think before pausing here, I really wanted to emphasize, what I heard also in Corey and Francisco's presentation or component, that it's so much about relationship building and building trust so that teams can work together. Our system is so fragmented. And so I think all the different ways that we're talking about here that we can connect and help develop people's skills, and knowing that there are others as part of your team who can help support these youth as well is really what it's all about. Thanks.
Thanks so much, Petra. Just appreciate your vision and everyone else's vision for CAP, and what a great, important resource it's offering. And more to come. So we'll have to have like a future webinar focused on CAP and the schools. Obviously, there's more time for need for deeper conversation. And again, this is just an initial kickoff series to have us highlight different touch points that a patient that involves a patient in our system. So just a quick follow-up on the case. And I couldn't, this case was evolving as the webinar series was evolving, so I really could not have told you what was going to happen. But we started a selective serotonin receptor inhibitor, SSRI, plan, a medication, and it was delayed because there's language barriers, I feel like, with the pharmacy, and the mom thought she heard that they didn't have the prescription there. I called the pharmacy, they said they had it there. This happens a lot, unfortunately. And the patient was also having the behavioral health team visits in our clinic. I just want to point out, he really was a little bit more specialty mental health, I would say. And so it's out of really not what our behavioral health team is supposed to carry. And so, but they were filling in because we couldn't get him into other services, which leads to burnout for our behavioral health team. I just wanted to point that out. And then the psychoeducation evaluation was pending. I was really grateful that the health plan care management services had involved the Support for Families of Children with Disabilities, a fantastic organization that many of you know in the Bay Area, who helped navigate getting his IEP going, his individualized education plan evaluation going, and following up on that. So again, it really highlights how there is a team approach, multiple services involved, all coordinated though, I would say, by the schools and also the health plan. His sleep was improved using some of the tools he received from the behavioral health team. And then there was a delay in some of the many subspecialty appointments that we had referred him to for things like possible sleep apnea, for example, because mom really wanted in-person visits. And there's like a telehealth world out there now where the visits were more telehealth based and easier access with telehealth, which, highlights some of the inequities, I think, in going telehealth based. But I do want to just highlight, I literally this week got this email from the school that said, just wanted to let you know that TM is looking so much better. He graduated 8th grade yesterday, reading from ear to ear. He's not been nearly as sleepy during class and looks like a new boy. I'm so glad that we worked together to help him. Thank you. like, it couldn't have planned this better. And I'm just grateful. And, to be honest, we don't know where this is going to, I'm sure it'll be a roller coaster, but it's just nice to know that when we can all coordinate, it really does. The family felt, I think, much more supported in their journey on this. I'm going to turn this over to you, Lauren. I know we're a little bit short on time. Apologies.
No, thank you so much, everyone. It was really great to hear from members of our school communities and also from my colleagues in the CAP program. So we'd like to take some time to break out in small groups and discuss kind of more about what we heard today, right? So think about and talk about what have you done to facilitate communication with schools in your practices, what is needed to make this happen, what's practical, and then what other tools, resources, or educational offerings would be helpful in order to engage in the resources we talked about today, the school resources and the CAP resources. So if we could open up our breakout rooms.
Okay. Well, we're whittled down to, as we expect with the small groups, but that's okay. We had a really great conversation. I really appreciate it. And I'm just going to briefly close this out here. And we will, I know I can say that in our small group, at least it seems like we need to have a conversation and like some training on what FERPA, HIPAA, what are the actual requirements, so we're not just like going off misinformation. And we would love feedback. Yes, there's a link to the evaluation in the chat, and I will just do the final sharing of some slides, I think, just so to bring us back. Am I sharing the right thing? Hold on a second. There we go. All right, yeah. So we've got the QR code for the evaluation. And then again, there's our HEAT webpage where all our materials and recordings will be. And just look forward to, please reach out to us, Cassandra and myself, with any thoughts, questions, ideas. And let me just stop sharing so you can see everybody again. Thank you all for joining us. We're gonna pick up again in September. We're gonna take the summer to plan. And start the webinar series again in the fall. But I already see some of the webinars we have to have from these discussions. So thank you so much, everybody. Thank you for joining us. Francisco, and if Corey's still here, thank you. Have a great weekend.
Okay.